We're going to wrap up our endocrine week by talking about parathyroid gland and calcium disorders. So we can find the parathyroid glands by locating the thyroid, and the parathyroid glands are located on the backside or posterior aspect of the thyroid gland. There are typically 4 of these, and you see them indicated in this photo here. They are really no larger than a small grain of rice. So they have a very important job, and that is to make the parathyroid hormone. And the parathyroid hormone is important because it helps in homeostasis of calcium and phosphorus. Parathyroid hormone is only one of the players that maintain homeostasis of calcium and phosphate. The other hormones that we need to be concerned about are calcitriol and fibroblast growth factor 23. Calcitriol is the active form of vitamin D. The other name is 1,25-dihydroxy vitamin D. So this is a simplified view of what happens to help maintain normal calcium levels. So you see right in the center of this chart in the yellow rectangle, it states homeostasis of the blood calcium level. So if you follow that to the left and you see the number 1, it talks about what happens if our calcium level rises. If the calcium level starts to go up, our thyroid gland is activated to release calcitonin. Calcitonin then helps the blood calcium level falls and returns them to normal levels. However, if our calcium levels start to fall too low, our parathyroid then is activated and blood calcium and releases a parathyroid hormone, which helps blood calcium levels rise, again bringing it back to the homeostasis of our blood calcium levels. So as we've seen in all of the endocrine system, there are these feedback loops that continue to help maintain normal levels of hormones in our body. So the main job of the parathyroid gland is to release parathyroid hormone to help control calcium levels. It helps also to control phosphorus, which is a mineral, and vitamin D, a hormone that is in our bloods. And the parathyroid hormone works on bones, kidneys, and the small intestine. And I do have some images, in some upcoming slides showing this. But the parathyroid hormone does stimulate the release of small amounts of calcium from our bones into our bloodstream. Kidneys, the parathyroid hormone works here to enable the production of vitamin D, calcitriol, in our kidneys. And the PTH also signals our kidneys to retain calcium in the body rather than flushing it out, and to help get rid of phosphorus in the urine, because as we're going to see in some upcoming slides, calcium and phosphorus work opposite of one another. In the small intestine, the parathyroid hormone signals our small intestine to absorb more calcium as well as phosphorus from the food that we eat. So as a summary, our parathyroid hormone is secreted by the parathyroid gland when our calcium levels start to fall. It is secreted quickly when there are small reductions in ionized calcium. The increase in the PTH helps to increase calcium. It acts on our kidneys by stimulating calcium reabsorption, inhibiting phosphate reabsorption, and it helps increase the activity of 1-alpha hydroxylase, and that's involved in forming the active form of vitamin D. It also acts on the bone, and our parathyroid hormone is an antagonist of calcitonin. So we saw calcitonin was released when our calcium levels are high by the thyroid gland, and when our calcium levels are low, our parathyroid gland releases the parathyroid hormone. So this was just a great picture that I had found on the internet. I'm sorry I don't have it cited here, but this was a great pictorial display of what happens when our serum calcium numbers fall. Our 4 parathyroid glands are activated, PTH is released, it works on the intestines, the kidneys, and the bone to help increase calcium. This negative feedback loop then goes back to the parathyroid gland, and hopefully we'll stop the secretion of PTH, because hopefully at that point our calcium levels are normalized. So we've talked some about calcium and its importance in parathyroid hormone, but why does it matter? Calcium is important in the formation and metabolism of bone, and most of the calcium stored in our body is in the bone. Bone tissue serves as a reservoir for and source of calcium for critical metabolic needs through bone remodeling. And you remember osteoclasts and osteoblasts, all a part of that bone remodeling. And if you don't remember that, it might be good just to review that in your text. Calcium also provides hard tissue with its strength. And in the circulatory system, extracellular fluid, muscle, and other tissues, it helps to mediate vascular contraction and vasodilatation, muscle functioning, nerve transmission, intracellular signaling, and hormone secretion. Calcium level can be tricky to monitor and to maintain because it is dependent upon vitamin D levels. We need to have appropriate vitamin D levels for absorption of calcium. It also is dependent upon kidney function, other illnesses in bone health, GI health, and parathyroid gland function. So as our calcium goes up, our phosphorus goes down. And what does phosphorus do in our body? It helps with bone growth, energy storage, and nerve and muscle production. Calcitriol. This is the biologically active form of vitamin D, also known as the 1,25-dihydroxy vitamin D. This helps to increase the amount of calcium and phosphorus absorption in the intestines. And so in order for us to have appropriate calcium levels, we must have appropriate vitamin D levels as well. It helps to prevent calcium loss from our kidneys, increases the renal absorption of calcium in two different portions of our kidneys, of the nephron, and it stimulates bone calcium mobilization. Functions on bone and kidneys require PTH. Calcitonin is made and released by the C cells in our thyroid. This decreases blood calcium. So if you remember back to that slide at the beginning of this PowerPoint, the diagram kind of showing what happens when our serum calcium levels are high, our thyroid level gets activated, our thyroid is activated to release calcitonin. This opposes the action of parathyroid hormone. Calcitonin blocks the activity of osteoclasts, which are cells that break down the bones. When osteoclasts break down your bones, the calcium from your bone is released into the bloodstream. The temporary blocking of the osteoclast by calcitonin reduces the amount of calcium that can enter your blood. Calcitonin also decreases the amount of calcium that our kidneys reabsorb and release back into our bloodstream. Fibroblast growth factor 23. This is a bone-derived hormone. It regulates phosphate and vitamin D metabolism. It's secreted by osteocytes and osteoblasts, and they work in binding a certain receptor factor. It also suppresses proximal tubular phosphate reabsorption by reducing the expression of sodium phosphate cotransporters. This is just another diagram. I think the parathyroid gland and the whole endocrine system at times can be a little difficult to kind of keep track of, so I like to include these visuals here. So the parathyroid gland, when calcium levels are low, releases PTH into the bloodstream to increase calcium. This then acts on fibroblast growth factor. It stimulates vitamin D synthesis within the kidney, increases calcium absorption, and decreases phosphate reabsorption. So this is just one more picture for those of you that like a little more color. We have the parathyroid glands on the backside of our thyroid, and when our calcium levels start to drop, parathyroid hormone is released. It acts on our bone and kidney. In the bone, we can see the bone breaking down to release release calcium into the bloodstream. In our kidneys, it helps with calcium reabsorption and helps with vitamin D production, which then in turn can work in the intestines to help with more calcium absorption, all to help increase the calcium levels in our blood. One more picture here, or more of a diagram, not so much of a picture. So in the blue, in the center of the two rectangles, we have normal blood calcium. And then if we follow that to the right, we can see what happens if the blood calcium starts to rise. The PTH is suppressed, which helps decrease bone reabsorption, increase calcium urinary loss, and decrease the vitamin D3 or calcitriol production. And then if we go back to the normal blood calcium, the blue on the left side of the screen, and we follow that to the right, we have falling blood calcium levels stimulate PTH, increase bone reabsorption, decrease calcium urinary loss, and increase calcitriol production. So now that we are all experts in how the parathyroid gland works to help maintain calcium and phosphorus homeostasis, we're going to talk about what happens when our calcium levels do start to become abnormal. So again, one more picture. So hopefully one of these will stand out to you as one that's visually appealing to you and can help you understand this process. I really do like this slide. Probably this one's my favorite, the blood calcium level. We see what happens on the right when it's low and on the left when it's high. Remember, when it's low, it's the parathyroid hormone is released from the parathyroid gland, works on the bone, on the kidney, and the intestines. And when it's high, our thyroid gland is activated to release calcitonin, which stimulates the calcium deposition in the bone and reduction of calcium uptake in the kidneys. So hypercalcemia, elevated levels of calcium in the blood. When our feedback system isn't working correctly and we see the calcium levels start to rise, many times this is found incidentally on a blood draw that we're doing for something else. The most common causes are hyperparathyroidism and malignancy. So hyperparathyroidism is usually long-standing. These patients are typically asymptomatic. They can have borderline to mild elevations, often below 11. They do appear healthy when you see them in the exam. The other cause, malignancy, is usually evident by the time hypercalcemia is found. These people are usually ill-appearing. They have higher levels of calcium, usually above 13. Primary hyperparathyroidism is sometimes asymptomatic. When it does have symptoms, there is this nice mnemonic. Well, I don't know if it's actually a mnemonic, but a way to help remember the clinical presentation and symptoms patients can have. They can have painful bones, kidney stones, abdominal groans, psychic moans, fatigue overtones. Notice how they all rhyme there. And hypercalcemia. We will be learning a little bit more about the kidney later in the semester, and we'll see when we study kidney stones that hyperparathyroidism is one of the major causes. So people who have repeated kidney stones, we need to be looking at hyperparathyroidism. This is typically caused by parathyroid adenoma, which is non-cancerous. PTH secretion is inappropriately high in relation to serum calcium. So if you think back to all of those images and diagrams that we talked about earlier in this PowerPoint, when our calcium level falls, our PTH should go up. So when our calcium level goes up, our PTH levels should be going down. They balance each other. But what happens in hyperparathyroidism caused by parathyroid adenoma is we see the calcium levels high and the PTH levels high. The feedback system is not working. Also, there is secondary hyperparathyroidism, and this is common in kidney failure. It is an increased secretion of PTH due to hyperplasia of the parathyroid gland. This typically is caused by hypocalcemia, hyperphosphatemia, or decreased active vitamin D. The increased PTH secretion in turn causes increased calcium in the blood by acting on the bones, intestines, and kidneys. So with our hyperparathyroidism, we can see the parathyroid adenoma or secondary hyperparathyroidism common in our chronic kidney disease patients. With hyperparathyroidism, it is autonomous. There's usually one hyperfunctioning node and more common in our ambulatory patients. Malignancy is also autonomous. We see the high calcium but low PTH levels. We also see low vitamin D levels. This is caused by parathyroid hormone related peptide. So when we see a patient who has elevated calcium but low PTH, then we need to check a parathyroid hormone related peptide. If that is positive, then we're looking for the tumor or malignancy. In our patients who have malignancy, they are not feeling well. This is more common in hospitalized patients. So the hyperparathyroidism and malignancy account for about 90% of the cases of true hypercalcemia. So we can see other causes of hypercalcemia, but these are what we're going to concentrate on in this PowerPoint. So this chart is nice, just stating what the presentation for our patients are with hypercalcemia and physical signs. Remember our painful bones, kidney stones, abdominal groans, what we talked about a few slides back, and we can see how that fits into this chart here. They may have a neck mass if they have some adrenal gland hyperplasia. Their reflexes may not be as sharp as they typically are. Constipation can occur in these patients as well. So we need to confirm their hypercalcemia. When we see it in a blood draw, we need to do it again, make sure that it is correct. And we might have to correct for albumin. 40 to 50% of our calcium is bound to protein, which is usually albumin. We should also be checking their vitamin D levels. As we see with malignancy, those vitamin D levels can go down, and check that PTH level. If it is elevated, we're going to be thinking of hyperparathyroidism. If it is low PTH levels, we're going to be thinking that it's more common with a malignancy. So then we will check the parathyroid hormone related peptide. If the PTH level is normal to mildly elevated, it still may be hyperparathyroidism. And with our patients, we would much rather see the elevated parathyroid hormone with elevated calcium and pointing to an adenoma as the cause versus a malignancy. Other things we'll check is a CMP, especially with our secondary hyperparathyroidism. We want to see what's going on with the kidneys. So if our PTH is high, we'll be checking that vitamin D level and parathyroid imaging. If the PTH level is low, we're going to check the parathyroid hormone related peptide and look for the cancer. This should account for 90% of our hypercalcemia patients. Remember, there's always those 10% where there are other causes of the hypercalcemia. When we see this, we should be referring our patients to endocrine, to our specialty friends who can manage this better. Treatment: if calcium is under 12 with symptoms or greater than 14 with symptoms, without symptoms, aggressive hydration, loop diuretic and salmon calcitonin. Tachyphylaxis can occur. With PTH levels being high, we might need to do surgery. And if it's malignancy, the treatments are listed below. Again, being managed by endocrinology, though, not by primary care. So the exact opposite now. Our calcium levels are low. And this chart is great just showing that. Remember, serum calcium levels low increases parathyroid hormone secretion, which works on the bone and the gut as well as our kidney. Hypoparathyroidism, most common causes are surgery. So perhaps these patients had some surgery on their thyroid or other structures in their neck. Maybe they have an autoimmune disease, abnormal parathyroid gland development, alteration of parathyroid hormone production or inadequate PTH secretion, impaired PTH action. Maybe they have abnormal magnesium metabolism, vitamin D deficiency or resistance. All of these can result in hypocalcemia. Calcium levels that are less than 8.5 are considered hypocalcemia. Normal levels are 9 to 11, and it can need immediate treatment if levels are below 6.5. In response to hypocalcemia, remember our body's natural systems to maintain homeostasis will increase the PTH. So this leads to mobilization of calcium stores from the bones and also increases absorption of calcium in the intestines. This is if everything is working correctly. Here's just one more diagram. You didn't know I could find another one, I bet. So the hypocalcemia, the parathyroid gland, is triggered to release parathyroid hormone, which acts on the kidneys and the bones to help increase calcium levels. And through that negative feedback loop, once we get those calcium levels normal, then our parathyroid gland can rest a little bit. But as we saw with hypercalcemia, there are times where our bodies just aren't maintaining these normal calcium levels. So signs of hypocalcemia include irritability, emotional instability, psychoses, memory problems, paresthesia, fatigue, muscle cramps, and weakness. It can have quite a few GI effects, including trouble swallowing, nausea, vomiting, abdominal pain and cramping, diarrhea, or constipation. And then we have our hypotension, bradycardia, congestive heart failure, or arrhythmia. So some very severe possible signs or presentations with hypocalcemia, depending on where those numbers are. Some other signs that we can see are neuromuscular. We know that calcium is an important mediator in neuromuscular transmission and other biochemical activities. When our calcium levels drop abruptly by 2 to 3 milligrams, we can see irritability of the neuromuscular system. And there are two signs in particular, Trousseau's and Chvostek's sign. And Trousseau's sign is reproducible in the office. This is a very painful contraction of the hands or feet, carpopedal spasm. We can elicit this in the office by putting a blood pressure cuff on our patient and inflating it to about 20 millimeters above the patient's systolic blood pressure. Leave it inflated for 3 minutes and we should be able to stimulate the violent painful contractions of the hand and feet. And Chvostek's sign is abnormal unilateral spasm of the facial muscle when the facial nerve is tapped just below the zygomatic arch to the earlobe. So I kind of think of the zygomatic arch near the temple area and the cheekbone, kind of lying right in there. If you look on YouTube, I'm sure you will find a great video of it, but this is something very simple to do in the office in our patients who have low calcium levels. Differential diagnoses of hypocalcemia, perhaps they're deficient in PTH. Maybe it's just acute or transient. Perhaps they've had a trauma such as a burn, sepsis, pregnancy, blood transfusion, acute kidney disease, or pancreatitis. So when we see somebody with low calcium levels, just like with high calcium levels, we need to confirm this. So we're going to recheck that calcium. We want to check their serum parathyroid hormone. We want to see where that's at. Check their metabolic panel. We are specifically interested in their magnesium. Hypomagnesium below 0.8 causes hypocalcemia by inducing PTH resistance or deficiency. We also want to check their phosphate and vitamin D levels, total serum calcium if normal serum albumin levels, or we could check serum ionized calcium. This is really the gold standard. It's more costly, more difficult to handle, but it does measure biologically free active calcium. These patients also need an EKG and X-ray. Remember, this can cause some arrhythmias. It can cause some heart failure. We need to see how their bones are doing. And this slide shows, just like what we did with the hypercalcemia, the presentation and physical exam. You will see the Chvostek's and Trousseau's sign here. And in bold-faced is laryngospasm. These patients, if they have severe hypocalcemia, can have life-threatening laryngospasm. So these would need to be sent to the emergency room for that. They can have EKG issues, diarrhea, hypotension, bronchospasm, confusion. They may have seizures if the levels are low enough, and they can have the perioral numbness and extremity weakness. Treatment of hypocalcemia, again, This should be managed by our endocrinology experts, but it is typically done with calcium and vitamin D. If the vitamin D deficiency is large, we can treat with the 5,000 international units weekly and 2,000 international units every day. These patients should be referred to the emergency room if they're symptomatic, and they should also be referred to endocrinology for hypofunctioning parathyroid gland. So that is the end of our endocrine system. I do have my references listed here. Please let me know with any questions.